Good afternoon. I'm Terry McGovern. I'm the Senior Associate Dean for Academic and Student Affairs at the CUNY Graduate School of Public Health and Health Policy. It's a super pleasure to welcome you to today's SRJ Voices session, hosted by our Sexual and Reproductive Justice Hub. I think what I want to say is in this incredibly difficult, turbulent environment at CUNY School of Public Health, we're doing everything we can to stick up for health and human rights. So we have created a Sexual and Reproductive Justice Hub, and this series is related to the hub. We have actually created a new master's in sexual and reproductive justice that was accredited and is starting off, the classes have begun. So we're very excited about that. And we have raised the funds and are interviewing for the Billy Avery Endowed Professor of Sexual and Reproductive Justice, named after Billy Avery, founder of the Black Women's Health Project, now BWHI. Just to say, we're so excited to kind of have positive momentum at a time that's very difficult. We remain committed to expanding and protecting access to abortion. And of course, this requires coordinated work across many sectors. An example of this work is the SRJ Hub initiative that was developed by today's moderator and some of our panelists in partnership with youth advocates, state public health and policy institutions, college stakeholders, and implementation experts. This initiative, Expanding Medication Abortion on College Campuses, an advocate's guide, intends to support advocates across the country who are working to expand medication abortion access on their own campuses. It's a resource the SRJ Hub is proud to share, and it reflects the kind of cross-sector collaborations that today's conversation and the SRJ Hub is all about. I'm sure Dr. Manze can provide more details on the project during discussion today. I want to say also we're super grateful to the legislature for supporting our work, and many other folks for supporting our work. And again, very happy to be engaged in positive work to ensure that health and human rights are available to all. So I am delighted to turn it over to our moderator, Dr. Meredith Manze, to start with some introductions, kick off the discussion, and introduce our panelists. Meredith.
Thank you so much, Dean McGovern. I am thrilled to be here. My name is Meredith Manze. I'm an associate professor in the CUNY School of Public Health, also with Terry. And I run our doctoral program and teach in the master's program. And most of my own work has been focused on expanding reproductive and sexual health services. So I'll tell you a little bit more about the study that Terry mentioned when we're talking a little bit more about how research can function as advocacy. I wanted to start with a little bit of background about when the seeds for this panel started, and it was now several years ago when I was working with Diana Romero and Heidi Jones, who were leading the evaluation of the Leadership Training Academy that trains clinicians in reproductive health advocacy. And we found that there were a lot of different forms of advocacy that we hadn't really thought of prior to that. And we might hear a little bit more about that from our panel, but things like yes, media advocacy and policy advocates, but also advocacy within their professional organizations, within medical education, and things that might be considered kind of more quiet advocacy efforts, including just the clinical work of providing abortion care and being a community of supportive providers with one another. So that's kind of where it started. And then last year, the study that Terry mentioned, I'll just say briefly, was a study of stakeholders involved in passing or implementing legislation in 4 different states to expand medication abortion access on college campuses. So thinking about their advocacy, but also research itself as advocacy. And we'll talk about that in a minute. Right now, I'm really excited to be here with our panelists and to have them introduce themselves. If we can start off with Silpa, just so everyone can share their name and their pronouns, a little bit about your role and kind of the big picture of what your abortion advocacy has been. Thanks.
Hi, everyone. My name is Silpa Srinivasulu. I use she, her pronouns. I'm the interim co-executive director of the Reproductive Health Access Project, or RAP, which is a national nonprofit that trains, supports, and mobilizes primary care clinicians to ensure equitable access to sexual and reproductive health care, including abortion. At RAP, we believe that abortion is essential healthcare, and everyone, everywhere should be able to access the reproductive healthcare they need and want with dignity and respect in their own communities, in the same health systems they're familiar with, and with the same providers they trust for the rest of their healthcare. In my role, I oversee our clinician education, training, and advocacy programs, and I also conduct original research and evaluation projects. And I'm also a PhD candidate at the CUNY School of Public Health, studying the implementation of medication abortion in primary care.
Thanks so much. Tamara, you want to go next?
Sure. Hi, everyone. My name is Tamara Marzouk. I use she, her pronouns, and I am the director of abortion access at Advocates for Youth. Advocates for Youth also is a national nonprofit, and we focus on supporting young people and adult allies in furthering sexual and reproductive health rights and justice in their communities, and building power to transform policy in order to move towards bodily autonomy for young people across the country and across the world. I also am a full spectrum doula, so I support people through all sorts of pregnancy outcomes, including abortion, loss, and birth, and postpartum. And I am a therapist as well. And so my abortion work lies in Advocates for Youth through policy advocacy, through culture shift work, through storytelling, abortion storytelling work, through practical support, where we support young people in becoming abortion doulas and sources of information for their peers around abortion access. And then I also engage in direct support and support with abortion destigmatization through working with clients in a mental health capacity as well.
Thanks so much. Stacy, you want to go?
Yeah. Hi, everyone. Thank you so much for having me. I'm Dr. Stacy Sun. I'm an OBGYN and family planning subspecialist at the University of Rochester. I've been in Rochester, New York for around 6 years now. So I provide full spectrum OBGYN care, including abortion and contraception. I also provide, complex abortion care as well. And so since being here, like a lot of what I have been doing is institutional advocacy as well as legislative advocacy. And that's kind of like my predominant forms of advocacy. In terms of institutional wise, since being here, we've been able to increase the gestational duration. So now we go up to 26 weeks. And we've also increased the use of moderate sedation as an outpatient procedure. So typically a lot of these procedures sometimes are limited to the spaces that they have to be in. And so being able to place it in spaces that are a little bit non-stigmatizing or a little bit outside of the hospital system is often really nice for people. It's a big effort to bring doulas into the office too. So we've been able to do that. That's been really great. And then I've also helped start a complex family planning fellowship. And so in terms of the institutional wise, it's kind of what I do. In terms of legislative, I also sit on the Informed Consent New York Coalition Committee. I'm on the ACOG Political Action Committee, the national one. And then I also on the ACOG District 2 legislative committee. So there's a couple of things that I work on. I also work on the research side as well. So I have a couple of research projects and a couple of grants going on at the same time. Yeah, it's a lot of work, but it's all for a good cause.
Fantastic. Thank you so much. So it clearly all of you, your work intersects with research, policy, and clinical training in different ways. So to start, I was wondering if you could each tell us how you understand the relationship between those three things in shaping abortion access today.
I can start. So I see abortion access today as really a product of a system shaped by structural abortion stigma, sexism, and white supremacy. And we see this because abortion has long been intentionally carved out of mainstream healthcare. It's treated as exceptional, risky, or even morally suspect instead of just a standard part of healthcare. And that stigma has really been embedded into policy, medical education, and health systems in ways that reinforce each other and also impede access to care. So, for example, the FDA regulations on medication abortion and abortion's exclusion from public insurance coverage make it seem like it's illegal or seem like it's really complicated to provide this care in a community-based clinic that gets federal funding. That sense of fear has even been extended to miscarriage management or early pregnancy loss care. In clinical training, that same stigma has meant abortion is often omitted or siloed from medical education, leaving many primary care clinicians undertrained, unsupported, or uncertain about the extent to which abortion care is within their scope, even when it absolutely is. And I think research as a tool and platform for advocacy within all these systems plays a critical role in disrupting the cycle of stigma. So, for example, we know for the past 25 years, research has been making visible what stigma obscures. That medication abortion, for example, is safe, feasible, and highly compatible in primary care and community-based settings, but it's still not as widely adopted as it should be. And so, in an example, through my research and role at RAP, I examine how clinicians and health systems are able to integrate this care. And so I'm identifying the concrete conditions that make it possible to expand access, even within a tumultuous political environment. And I'm learning and sharing the strategies that organizations, clinic staff, clinicians, that they can all employ to truly change the culture and systems of their institutions to expand patient-centered and trauma-informed access to comprehensive reproductive health care. And through this research within RAP and with other organizations working on similar projects, together we're all providing a roadmap for others to adopt such practices and strategies and truly expand abortion access community by community. As a quick example, I administered like a pre and post survey for clinic staff at organizations that want to provide medication abortion and asked staff about their sense of acceptability, readiness to provide abortion, comfort, belonging in primary care, as well as their concerns for offering it in their clinic. And out of that, we learned that most staff do believe in offering their patients abortion access, but they have concerns that largely come out of the larger political environment, out of misunderstanding abortion care, out of priorities for ensuring things are done in a safe, feasible, and intentional manner for their colleagues and their patients. And so we had all these kind of senses of concerns and challenges, and we didn't just use these findings to help organizations create a plan for implementation. We've also been applying them to trainings and toolkits. So, for example, we launched and updated a brand new abortion or integrating abortion in primary care toolkit based on these lessons learned. And we recently tested out a values clarification train the trainer session with the National Abortion Federation and the New York Abortion Access Program, using these real life themes to train clinicians on how to respond. So I think this is just one example of how research, training, and advocacy can come together to rapidly make change and support efforts to increase abortion access.
Thank you so much for that, Dr. Sun.
Yeah, I would echo the idea of stigma really affecting how people care and how we approach abortion care. Right? I think a lot of the stigma around self-managed abortion still is very, very strong, even within the provider realm. Providers, all sorts of providers, doesn't matter what kind of provider one is. And so one of our studies that we've been trying to work on is self-managed abortion and understanding our attitudes towards it and how providers have changed or what has changed, and what can we do to make it more acceptable, understand the evidence, and understand that it is safe and very helpful for our patients across, especially in restrictive states. And so that's one of the research we've done. In terms of research, I think that research is inevitably intricately linked to policy change, to work in the clinical forefront. And that one is not without the other. It's kind of how we think about abortion care is not without maternal health care. They are one and the same, gender affirming care as well. And now siloing it really just stigmatizes it and makes it its own and makes it its other when it's really not othered. And so just like research policy, you can't have policy without research driving it. You can't have but without policy or someone in the policy forefront, you also can't, the research doesn't go anywhere as well. And so it is I always think of it as like advocacy. It's like an advocacy web of all the things that must link in order to make things work well. So having people powerful on all different forefronts and whatever you choose is one of the key things.
Yeah, I so agree about the intersectional and interwoven nature of the three. And, as I was reflecting on this question, I'm thinking about the power of storytelling and how, at their best, research, clinical training, and policy all are forms of storytelling and are allowing people to really center folks who need access to abortion and who have abortions. And so I'm just thinking about, research is a way that we can, especially I'm thinking about qualitative research as a way to really bring in voices from young people, from people who have had abortions, people who are in need of access to abortion all across the country. And I think that at its core, that is what research can do, is bring these stories to life and then move them into practice. I think that clinical training also at its best does that, really centers the experiences of patients, of people who will be in the room with you and thinking about, okay, how can we meet this person's needs in the best way on a micro scale and then also on a macro scale through policy work. And one way that we have brought all three of these together and really see all three in practice is at Advocates for Youth. A lot of young people across our programs have been advocating for medication abortion on campus bills in different states. And so we've worked in partnership with folks in California, but then also we've worked with students in Massachusetts, New York, and now Washington State to advocate for legislation that makes abortion more accessible for college students. And on one end of the spectrum, that means requiring medication abortion services through campus health centers. And on the other end of the spectrum, it means if that's not a possibility or if there are no health centers, at least having a strong referral system, warm handoffs, so that if someone needs access to abortion, their campus is able to meet that need and support them through it, as opposed to saying, okay, here's a piece of paper, go call Planned Parenthood, call a clinic, whatever. So I really see research as so helpful in shaping our understanding of the need, not only for students and understanding what needs they have on campuses and what gaps are needing to be filled in terms of access, but also zooming out, thinking about the abortion landscape nationally and thinking about how many clinics are overwhelmed by travelers in access states and in places where they can meet that need, but maybe waiting periods are much longer now, so data and research about what is happening nationally makes the case for additional access points and helps us provide campuses with the understanding of a unique responsibility to potentially become an additional access point for young people. And then clinical training, Silpa mentioned so much of the myth busting, I think, around clinical training. And we see that so much when we're working with college health centers and we're working with folks who really, understandably so, because of the stigma, have so much internalized fear around providing abortion services or around even what it would take to get to a point to integrate abortion services into their primary care practices. And so, we work with young people to educate folks constantly about these myths, whether it's, okay, it's going to cost millions and millions of dollars, or it's going to mean that we're going to need to hire someone who only specializes in abortion as opposed to adding it to their care services, or training staff that is currently existing. So I think myth busting is such a huge part of that clinical training. And we've seen so many folks go from, oh, no way, I could never, to, oh my gosh, wait, this is much less expensive and much easier than I thought it would be, even though I had fears about it. And that's in large part thanks to organizations like RAP that really support clinicians in moving from point A to point Z. And then I also see that policy shift, we have advocated for policies for state legislation that has really tangibly changed young people's lives across the country, and really made it so that campuses feel that responsibility to their students so that they can meet needs as they arise.
Thank you so much. So in that medication abortion study that we had mentioned prior, Tamara and Silpa collaborated on that, and it reminded me of my favorite quote from that study is, one of the policy advocates who essentially said stories and statistics is what you need in terms of the storytelling from students themselves, and also the research that provides the statistics about the unmet need. So thank you all so much. So with all of that in mind, what do you feel like is the most urgent right now in your respective areas of work, and how do those priorities kind of intersect? Dr. Sun, do you want to start?
Sure. There's so many. I would say one of the things that for me particularly is like how do I combat this on different sides? And so how do I improve access for our patients as well as make sure our providers are getting trained, right? And so we're lucky enough to be in a New York State where I can train a lot of people. And so how can I bring people from other states who don't have the training or who are like unable to do so? Um, and so for those people to then return to their states to be able to provide care in those necessary moments, right? So a lot of institutions, simply because you are in a non-restrictive state as a provider, it does not equate to training. And so training is a very specific site-to-site kind of entity. And so a lot of what drove me to start a complex family planning fellowship was out of necessity, not necessarily, it was truly out of the feel of like advocacy that I'm trying to look for people who need that training or want to return to a state that may have very few OBGYNs, very few family planning providers. So that is like one of the things that I've been really working on. The other part that we've been really working on is like, how do I ensure that the patients that are in Western New York don't have to travel to New York City to get the care that they need, right? And I don't know if like Western New York is this huge landscape and takes hours to, so a lot of patients, cannot afford to get all the way into New York City to get the care that they need. And really like we are one of only if like we are the catchment area of the entire Western and sometimes upstate New York for people of advanced gestational durations. And so having that and making sure that I was able to increase gestational duration and making sure that people are still on board. So that's one of the things that I've been really trying to focus on, and like what can I do in the space that I have, in the time that I have, in the privilege that I have, right? And so like being able to put those all together, and that's what I've been able to do. So knowing that like there's this lack of trainings plus a lack of like understanding of where one can get care. That's the way I've been approaching it. Obviously that's one of many different things the other panelists will talk about.
Thanks so much, Tamara. Do you want to go next?
Sure. Yeah. I mean, I think we could all come up with like 1,000 urgent things. But one thing that really comes to mind for me is something I see every day in working with young people, and that is just the power of community and reminding ourselves that we have each other. I think it is very easy to feel very isolated in this work in the face of state-sanctioned violence. I think that the more cross-movement collaboration we can do, and the more we can realize that, reproductive justice is a cross-movement issue. Every single issue is connected to reproductive justice. The the better we can do in terms of showing up for each other. And I think that when I think about what is urgent right now, I think restoring whatever semblance of a sense of safety we can have and find in each other, in our own lives, with people that we feel safe with. I see this across all realms of my work, not only to advocates, but also, as a doula and as a therapist. I think however we can just ground into and remind each other that we are here for each other, and that this work, we will continue doing this work. I think bringing folks in who are curious about the work, whatever that looks like. I'll talk a little bit later about kind of what I think it means to, take care of yourself in this work. But I think bringing folks in who are curious, who are asking you questions, I think there is so much power to one-on-one conversations that can support people in getting involved when previously they felt kind of paralyzed, which I think a lot of people are feeling right now. So that feels urgent to me.
Agreed. Silpa, what about for you?
I'm reminded right now of just how grateful I am to be part of a movement where there are just so many brilliant people working toward the same goal of protecting and expanding access. And so, also, while I feel like there are others who are tackling misinformation needs, the immediate needs of providing abortion access to those in states with bans, or protecting clinics from being harmed from protesters. Um, there's just so many things that people are working on, which is amazing. But I think what I see most urgent in my work right now is the long-term sense of sustainability. I feel like we're constantly fighting for the problems of right now, which of course we need to address. But I also want to be in a space where we can, start creating the world that we want to see for our future. Um, and again, abortion is just seen as so exceptional because how it's been historically and presently treated like something other. But when it can truly be brought into the mainstream, then we can better protect care from such political attack. Um, so that's the work that I want to prioritize right now, which is really sustaining and building this primary care infrastructure and workforce to provide abortion so that it can truly become normalized and accessible. Um, but if this infrastructure is going to be a reality, and from a policy perspective and how it intersects with research and practice, and maybe this is idealistic, but the Hyde Amendment needs to go. And for those who don't know, the Hyde Amendment is a rider that has always been attached to congressional spending bills and prohibits any federal funds from being expended toward abortion. So this clearly affects federal Medicaid dollars, but it also affects institutions that receive a lot of federal funds, like federally qualified health centers or other essential providers. But these are the places where the majority of people who face barriers to care go. These are also the community sites and the clinicians that should be offering this care to them. So to really create a sustainable and equitable infrastructure that can withstand political attack, I think our long-term policy priorities need to be dismantling the Hyde Amendment and any other federal efforts that attempt to block public funding toward abortion access.
Thank you. So with that in mind, we have touched on kind of how, as a nation, we are amid an ever evolving or devolving political landscape that impacts significantly how abortion care and advocacy can be carried out. And so, how do the policy shifts at different levels, the local, state, federal levels, shape the day-to-day work that happens for advocates, clinicians, and researchers? Dr. Sun, do you want to take that?
Or I'll start. Just from a really we're looking just down to a patient standpoint. A patient comes in and wants an abortion, like what happens? So a lot of our patients in New York State can be covered by Medicaid. And so Medicaid is, just to remind everybody, is insurance that can be covered for pregnancy patients, but it only is in New York State because New York State is the one that funds it. And to echo what Silpa was just talking about, is that the Hyde Amendment prevents any federal dollars to going into any patient's abortion care. And so that we are lucky enough that the state will help us fund Medicaid. And so if we're thinking about state funding, right? State funding cuts Medicaid. One of the first things that will go can be abortion, right? Can be postpartum care, can be anything that we have just recently, people will find, oh, we don't really need that. That's the bottom of the list, right? What's the least important to them? And so that is just the budget is on the table right now, right? The budget is literally on the table at this moment. Kathy Hochul is working on this right now. And so we know that budget is integral to our care, day-to-day care for our patients. And so that's just one example, and that it's active, it affects us. I need to know what the budget is. It's relevant to all of us. So that's just one part. But if we're thinking if I'm thinking locally, then locally, I know that my institution, just because doesn't necessarily follow the state does, right? And so institutions, the state in terms of gestational duration doesn't really have a technical limit. So it has a limit what they say, but a lot of abortions can be done for really extreme circumstances, sort of like people who need complex psychosocial needs, people who have severe genetic anomalies. There are very, very complicated, nuanced reasons people need abortions. But that doesn't mean the institution is okay with it. That doesn't mean your chair is okay with it. That doesn't mean the senator that you work with is okay with it. And really working on those local people and that social capital and that buy-in from that small standpoint can make such a big impact. I feel like 10 years before, we were only going up to 20 weeks or so, and then we trickled up to 22 weeks, which took another 5 years. In the last 5 years, I've been able to give us up to 26 weeks. So it takes so much time and so much effort and so much buy-in from every single person to know and to based on the studies that we just talked about, right? The Turnaway studies, this huge study talking about what happens to people who don't get abortions, what happens to them, right? It's almost like a no duh kind of a study. Of course, people who don't get their abortion don't do well in life, right? But we had to do that. So, that we had to do that study, not we, but I would say a community of research had to do that study in order to prove something that we knew it was likely already existed. And so every single research question that we do is to drive the policy and to drive our institutions on a local, national, federal, state-wise to be able to better care and access.
I think the landscape today is extra challenging because it's not just impacting abortion care as a service, it's impacting every aspect of health, science, social services, human rights. Clinicians and all of us are working in a system that's losing funding stability from Medicaid cuts. Gender affirming care services are under an explicit threat. Many institutions have stopped providing pediatric hormone care because of fear of retaliation or an explicit indication that they can't. Hospitals that are critical access points for maternity care are closing because of funding. And this is the kind of environment that clinicians are operating in, and in a world of increasing distrust and confusion around science. So, like in this environment, health systems are trying to figure out how to sustain the care they already provide, trying to understand the risk landscape and being off the radar of the federal government, trying to hold on to the clinicians and staff they currently have, and also just navigating this chaos personally and professionally. And so, this is also the environment that people like Stacy are championing, like the integration of abortion care into their clinics. That's what they're trying to navigate right now. The leaders that they're trying to persuade are more risk adverse than ever. The staff who need to implement one protocol, one change to scheduling, one change to after hours calls, one supply order, they're exhausted and overburdened, and misinformation abounds more than ever. Questions like, is it safe? Is it legal? Are protesters going to come to our clinic? What if something happens? So this all makes like what could be a simple counseling visit or a medication dispensing process more complicated and time consuming and complex. And all that effort to build buy-in and trust and ensure that the clinic systems are set up to offer this care in a patient-centered and sustainable way, it's even more time consuming. Um, and then to add on this example with like a research perspective, this is also the environment that researchers are struggling in to conduct studies in like a funding perspective, but also one where we're trying to tease out the answers and causes in this environment. So, for example, what are the real barriers and challenges to implementation? What is misinformation or fear? But something that I've been learning lately is that this is the reality of abortion research. So our questions and methods are always going to be impacted by a larger political environment. And so what we ask and what we find needs to be immediately translatable to a broader community who is working in this environment.
So thankfully, we still have people who are entering this landscape, and it demands obviously both skill and resilience. And so we touched on a little bit in terms of self-care and sustainability, but what forms of preparation or support do you feel like are the most essential for new advocates entering this work today? Tamara, do you want to kick us off?
Sure, yeah. So at Advocates for Youth, we work with a lot of young people who are just starting their advocacy journey and thinking about where they want to plug in. And so, um, yes, it requires skill, but I think one of the biggest things is recognizing you do not have to do it all. And it's more important to just know where to go for answers than to have the answers yourself. And so I think making sure that you are connecting with local organizations who are doing the work, whether that's policy work or care work directly or practical support or funding work. So getting connected to organizations that are there that you can trust. There are a lot of organizations out there whose sole purpose it is to spread misinformation and disinformation. And so it's more important than ever to find out what resources are trusted resources that you can go to for accurate information. I think that's one of the biggest pieces is finding places where you can rely on these people in your communities or organizations nationally that you know are going to provide you with accurate, comprehensive information. I know, yes, it also takes resilience. I agree. I think resilience is so important and also can be so exhausting. And so I think um, really pausing and thinking about what you are saying yes to. I really recommend folks kind of take a step back and think about what is feeding them. I think as activists, I'll speak for myself, it's very easy to say yes to everything and to get into many different forms of advocacy, which I think is wonderful and amazing, but the road to burnout is very quick often. So I think just taking a pause and checking in about what is feeding me, what's draining me, what can I say yes to more, what can I say no to more, and even pausing before giving someone an answer about whether you're ready to get engaged or not, and really thinking about, okay, how does this sit with me? Is this in alignment with what I have capacity for, or what I want to continue to get engaged in? Because there are a million different ways that folks can plug in, and really only you know what will feed you. And sometimes it takes a lot of trial and error. I always recommend that folks set an alarm on their phones for the same time every day to just stop whatever you're doing. And even if you're in a meeting or something like that, just to kind of check in, like, how am I doing right now? How's my body? What am I feeling? Because it is so easy for us to go through the world with our shoulders up in our ears and just hold so much, as folks who are supporting through policy advocacy, through care work, again, through practical support, through any form related to really any movement. But we're talking right now about abortion access. I think it's very easy to hold so much and take so much on, and then not recognize what's going on in our own bodies. And so I think in terms of resilience, I think the point is not to just be strong, it's to recognize when we need to slow down a little bit. And I think just back to the community care aspect, we can't do this work alone. And so I think a huge part of it is identifying who your people are and who you want to do this work alongside. Because yeah, we got to do it together.
Silpa?
I need to take your advice, Tamara. It's really great advice to set an alarm. But I also really echo what you're saying about community. I think it's really important for all of us to have a community of support to be part of, people to learn from, lean on, and also just to build a sense of solidarity and shared purpose and inspiration. Community is how you fill your cup to be doing the hard work of advocacy, especially the community you choose to be part of. And to do this against all odds, against the inevitable setbacks, doing it together is what makes advocacy and organizing joyful. And I think that's a huge part of what builds resilience. I also think we have really different skills as individual advocates. Not everyone needs to go in front of Congress or write op-eds or talk to the media. I think being able to find where your power is as an advocate can also help you build the confidence and resilience to keep doing this work. So, for example, I am not a social media person, and I know how important it is to use platforms that reach people, but I just don't want to put myself out there like that. But I like using platforms like this, or classrooms, or conference settings where I can represent and share my expertise at this intersection of primary care and reproductive health, at this intersection of research and advocacy. So I think finding where your skill set lies and being empowered to do that kind of advocacy is what helps create a movement of truly diverse and multidisciplinary people working in different but united ways toward those same goals. And I think lastly, advocacy training needs to focus not just on the content of abortion access, but the actual strategies and ways to navigate stigma, resistance, and ethical complexity. And this means learning to communicate about topics like abortion clearly and confidently, how to respond to biases and misinformation, how to negotiate for change or persuade people, using principles like shared values to bring someone else closer to your point of view, using storytelling to illustrate structural problems or solutions around abortion access. These are really nuanced skills that aren't taught or practiced for clinicians or for researchers. So I think the more that we can learn this, the more powerful as a movement of advocates we can be.
Thank you. And I'll say at the School of Public Health, I feel truly like we hit the lottery when Dean McGovern joined us, and we started the SRJ Hub together, and it is one of the things that has kept me going through the last few years. So I want to turn to that next, and to talk a little bit about research that's inspiring and motivating in the context of abortion access and advocacy. And so to what, to Silpa's point about finding where your, skill set, expertise, and comfort lies, I'll say that research is probably for some a little less flashy and exciting than media advocacy and other things, but it is for me where I feel like I can contribute the most and be inspired and motivated. And so at the start of the academic year in September of 2024 is as I was optimistic, but trying to be realistic about what I was going to need in the next year to get through the election and what might happen after that. A group of master's students needed a project, and I said, let's just, being in the privileged position of being a tenured faculty with a hard line of funding, we can engage in unfunded research. And at the time it was, and then subsequently funded by the SRJ Hub, which we were very thankful for. And so with master's students, with SILPA in partnership with Advocates for Youth, we started this project, and with every turn, it truly is what kept me going through 2025 in just with every awful piece of news, just reminding myself that in some small way I am contributing to kicking the can down the road in the ways that I can. And from that work, we interviewed 30 something stakeholders from 4 states who were involved in the legislation that either through advocacy, through passing it, or through implementing it in 4 states to expand medication abortion access on college campuses. And we are publishing a peer-reviewed paper, but in addition, we created this guide for advocates in other states to expand medication abortion on college campuses. And it's probably one of the things that I'm most proud of so far in my career that we've created, and something that can be, translatable and actually make an impact. So Silpa, I don't know if you want to share more about that project or other research that you've found that's kind of exciting and motivating.
That was like that, and that continues to be a really motivating project because there are so many, like I remember maybe around that time or a year before, it felt like every other month there was either a student from a student group from a college or like the health center themselves from around the country that were reaching out to us thinking like, I want to provide medication abortion here, like how do we do it? And there is so much need and so much interest. And so to have this like living toolkit truly informed by all these different stakeholders that is meant to be applicable in a different, like an array of settings, I think feels so it's so useful right now and for like every month and every year to come. And so that's been really exciting. And I know like people who are looking at it and using it. So I am very deep in my dissertation. So it's hard to be paying attention to all the research out there, but I have been very excited about like 2 kind of areas that are a little bit different than what I directly work in. But I've been really excited about work being done to study and translate evidence around the safe and effective use of mifepristone and misoprostol beyond 12 weeks gestation. A lot of this happens in a self-managed context, so it's been hard to safely collect and disseminate this kind of data, but organizations are working on not just studying this use of this kind of protocol, but also creating real materials for clinicians and patients to understand how to use the medication, how to take care of themselves, when to seek follow-up care when needed. And then relatedly, I've been really interested in tech innovations and how people, for better or worse, have been using AI for health information. And I think it's been really exciting to see how on top our movement has been of understanding the digital privacy landscape, pushing legislators to better protect people's reproductive health data, identifying the accuracy of information provided by AI platforms, pushing for abortion AI ethics to ensure information that people are accessing is real. And so I'm really interested to see how that work continues, what tech innovations will continue coming out, and how they can truly be used to expand access, information, and autonomy in a private way.
Thank you. And as Silpa's dissertation chair, I am very excited and motivated by her work and excited to see her finish this semester. So next, I'd like to turn to clinical work and knowing how the expectations of clinicians just continues to grow and grow, and so does the need for training that prepares them for those realities. Um, what do you feel like are the biggest challenges facing clinicians or trainees who want to provide abortion care or integrate it into their practice? Um, Dr. Sun, can you start?
Yeah, I think a lot of first of all, from our residency training and our across all the residents, they primarily, a lot of them come to us because we provide such thorough abortion contraceptive training. And it's one of the biggest reasons they come to our residency in the first place. Like we are the reason that they come. Um, and what I have seen is that like a lot of people who really want that training are really selectively going to residencies that can provide that training. And so it becomes very institution dependent, state dependent. And then what you then end up having is a lot of great programs getting unfilled. And so like people who can be great OBGYNs, except without the abortion training, are not like going to some of the southern states, right? And so, and where our patients there deeply need that care as well. And so it's like a self-compounding problem. The more people apply to certain states, the worse the training becomes over there. And so, um, it's just it just makes itself worse, right? And so, how can we integrate training in the states that are restrictive, right? Is the biggest question that a lot of us have is like, how can we better help them? And so, one of the ways that we have been trying to do so is partnering with other states and other institutions and literally just trading residents. And so our residents can go there and experience what it feels like to be there, and their residents can come to us to experience to get some abortion training as well. And these are really like institution driven. So like the residency directors, it's just like a very grassroots kind of way of working, right? One person has to be really motivated to help, or one person who wants that training needs to have the support of a mentor to can get them somewhere to get that training, right? And so, integrating it into the work, like I know, for example, ACOG and ABOG itself and ACGME does consider abortion training as integral and important to our work. That does not mean it gets done, right? And it does not mean at all. And so but there is nobody up there supporting the people down here, the job that they need to do. And it does take a lot of self-motivation from some of these residents. It takes a lot of and so what part of my job is what I try to do is I try to find people and how can we help others in other states, right? Knowing that we are privileged, how can we kind of bring students from other places who are interested? And then and just even outside the realm of OBGYN, right? How can I help my family medicine colleagues in my emergency department, emergency residents, physicians? How can I help them get the training that they need to be able to provide medication abortion in the ED, right? What information do they need? What kind of supplies do they need? So training can fall onto many different parts, physician assistants, nurse practitioners can definitely do it, in many, many different states. So how can we make sure that they're also trained? Because my goal is that I do fewer abortions, because if more other people can do the abortions, then I could do more of this advocacy section too, right? And so I think, I'm sure Silpa feels this way, as well as how can we get more people to feel comfortable to doing the abortions in different spaces, right? And so because it doesn't have to be me, not at all. It's not and I do not want it to be me. And that's something that I continue to say, that should not be me. My job is to try to disseminate that information at this point, because I feel you know, I have feelings about being siloed into a complex family planning subspecialist, right? And why that even occurred, right? There's a bunch of historical reasons, but like the biggest reason is because it's othered. Like when it comes down to it, it's othered. So my field is othered into a subspecialist. And that is just the way it is at this moment. And so becoming that subspecialist means that it's harder to get that training. And it is unfortunately the way it works at this moment. And how can I fight that, the place that I am in, to make it less subspecialized is what I've been trying to work on.
Thank you. Silpa, what are you seeing?
It's so wonderful to hear you talk about like your perspective, especially like in this true position of power, because like you said, ACOG and like the ACGME, like OBGYNs are supposed to be trained in abortion, and other primary care providers have it generally within their scope of practice. They can do it, but abortion is not an explicit competency within the ACGME. And it's like interpreted in a way that, yes, like broad pregnancy care. But it kind of what happens is that a lot of other primary care providers and their institutions, abortion training is not necessarily prioritized unless there is that director, that leader, the people who want to make it possible for their residents, for their medical students, for their nursing trainees and all of that. And I think what we see as a result is that training programs vary a lot around the US, around the quality and extent to which people are trained in even pregnancy options counseling and medication abortion care, which is mainly the counseling and the medication management, which is purely within primary care provider scope of practice. And it's certainly improved in the last decade or so, but it's still variable. And these are essential counseling skills and education skills that providers should have if they're seeing any person of reproductive age. And it offers them an opportunity to bring unbiased, trauma-informed abortion education and counseling, even if they're not ready or able to provide it themselves in that moment. I think when it comes to providing procedural abortion, the training landscape is getting harder. There are fewer places to see patients, to train providers, and patients are actually accessing medication abortion more. And maybe this is due to their preference, or maybe it's due to access barriers, or a mix of both. Um, and of course, like while laws have improved in many states to allow advanced practice clinicians to provide abortion care, there's still many places that do not allow them or restrict the care that can offer. And so it's still this constant battle of finding opportunities when you want to. Um, and then I think even once you're trained, there are so many more challenges to actually integrate this care into practice. I've mentioned the Hyde Amendment before, but I think there's also like leadership resistance. Unlike in most health centers, where a clinician within their scope of practice wants to bring a new service to their patients. So, for example, this is kind of how gender-affirming hormone therapy started in family practices. That someone just wanted to do it and they just started providing. It didn't have to become a whole thing. But for abortion, it's like a whole thing to get approval to provide. And in some cases, it's a funding issue. In other cases, there seems to be some like gatekeeping that happens. And so sometimes this comes from the C-suite. Sometimes it's an OBGYN department. Sometimes it's a medical director or a chair of the department. Every institution, every structure is a little different. But what ends up happening, and kind of this is the world that we're in now, it's that if you want to provide abortion care, you might not necessarily just be able to do it, but you have to figure out who is the decision maker and how do you convince them that offering abortion care here is feasible, important to patients, and financially possible. And I think like staff capacity, there's a lot of, because abortion is so different, the healthcare environment is really tough. There's a lot of like natural and unnatural turnover in primary care. And so when you're trying to do this kind of work, you need to actually have the capacity and the resources to do it and take the time to do it. So when you have turnover, it means that you have vacant positions, you have overburdened staff. And these people are the people you rely on, are your allies to help you investigate or create systems changes. And if they're not there or if they don't have the time, it becomes harder to make these changes possible. But I will say, like, despite these challenges, there are a lot of clinicians who have brought medication abortion and procedural abortion to their outpatient clinics, and there is a roadmap and a pathway to do this work and people to learn from.
Thank you so much. So, two more global questions to kind of end on a hopeful, informative note, and then we'll move to the Q&A. So if people have questions, feel free to put them in the Q&A. So even in challenging times, there's moments of hope and momentum that keep people grounded in their work. And so looking ahead as we push forward to defend equitable access to abortion and abortion care, what gives you hope about the future of abortion access and advocacy, even in the face of all these challenges that we've talked about?
For me, just like we've talked about, it's the community that really gives me that hope and still gives me so much optimism, because seeing our patients day to day face, being so brave and so, despite the hardships, feeling like today, for example, I had a patient who was crying to me because the crisis pregnancy center made her feel really horrible about her decision, and how she thanked us for normalizing it and understanding where she's coming from. And it's, just seeing her, and she just kind of poured her entire heart out, and feeling how brave she is to be able to say all these words, like be able to say these things that are nuanced and so hard and so real. And just, that just gives me a lot of hope, right? Like that she's braving it, I could brave this too, my own family, like my sisters, like who are all in this fight together, you know, the community I work in, like the senators that I have good relationships with, who are really, really supportive, the maternal fetal medicine, the high risk OB doctors who are so behind us in what we do, who are really, really supportive. The hospital, despite like there's always red tape with anything you do, my chair, it's just, it does add up, right? And finding that community is what really brings me hope. Like, I did not expect to come to a community and necessarily find myself home, but like feeling that, you know, you are making change. Like, it's taken many years to make change, right? But that one can make meaningful change, um, really like gives me a lot of hope. If I can make this change in 6 years, I could probably make more change in 10 years, right? Like, so I don't, I, and having the support from my personal family, it's just, and the people, and like being on this panel, and having medical students come up to me and talk to me, how passionate they are about the work they do, how like amazing they are, and how motivated I see people are, like really truly gives me hope. Um, so find the people that give you hope, right? Find those around you. We're not in the minority, right? That is the thing. Abortions are normal and not in the minority. So the more of us that we can be together, the more we can continue on.
Oh, I love that. That is so true. I feel super inspired every day. I will just say that there are some people in attendance here today that I've worked with through Advocates for Youth who have been incredibly inspiring to me. And I just want to shout out all the abortion storytellers. I feel so inspired by all of the folks out there who are sharing their abortion stories. I only by being in community with other abortion storytellers did I start to feel safe sharing my own abortion story. And I think there is so much power in that. And just like you said, Dr. Sun, that normalization. And I think seeing the normalization on an individual level and a collective level, and just being in spaces with 20 young abortion storytellers where it's not a thing. It's a part of our stories, but it's not the entirety of it, like many people would make you think. And so I think being in those spaces where it's just normal and we talk about it like brushing our teeth, it's it gives me a lot of hope that that world can continue to expand. I also feel really, really inspired by the curiosity that I experience from working with young folks that are starting to get involved in this. And I'm even as the Q&A questions are coming in, I'm struck by just the curiosity and the excitement. And I think that that is a really wonderful reminder for us to remain curious in this work and remain curious about our own roles in this work, remain curious about what's happening both like locally and nationally and globally. So I think the more questions we can ask, the more hope I have in some ways. And then the work that I am seeing young people engage in is just incredibly inspiring for me also. I'll shout out a couple of different things, but one is the Medication Abortion on Campus campaigns. And, Silpa, when you mentioned you've seen someone start a program on their campus and or a provider say, I want to do this. And I think we both know providers were like, I want to do this, and then a ton of red tape, or I want to do this, and then they experience support. And so I think every time I witness kind of a shift or a transformation from a lot of bureaucracy to we did it, that feels just so inspiring. And I have worked with so many students who have made that happen and worked tirelessly to shift culture on their campuses so that in partnership with providers or in partnership with legislators, they can increase access for students on their campuses, which is really, really amazing to see. And also, Advocates for Youth created 6 young people that worked with Advocates for Youth with myself and 2 abortion doula trainers, developed a 7-week abortion support curriculum. And we provide that every year virtually, but the work that I have seen young abortion doulas and abortion support people do with that curriculum and way beyond, and taking that into their own communities and training people in how to support a young person before, during, after an abortion experience has been really, really amazing to see. It's given me so much hope. It has been the project that I think I am just most grateful for. Just seeing people learn about abortion support and then learn about where they want to go with that, whether it's just sitting with someone on the phone or diving deeper into what they thought would be a medical career, or, so there's just so many different ways young people are taking this curriculum, training others, and that's just been really, really amazing to see and really, really inspiring. So yeah, I feel like it's a privilege, but I feel a lot of hope and inspiration every day.
Silpa?
I think I'm just really inspired by everyone here. I feel like sometimes I'm in a bubble of research or in a bubble of the mission of our organization. And when I hear stories and when I hear people talk about the work that they're doing or the impact that they're having, whether it's just on an individual level or a bigger level, like a policy change or a whole organization providing care, there is just so much hope and inspiration and like power to take from those moments. And that's what I think keeps me going, especially like there are so many easy ways to get bogged down in what's happening right now, personally and professionally. And so to take the joy that comes out of people's successes and experiences and stories is what truly keeps me going. And I hope the stories that we shared today can also be those sources of hope and inspiration and excitement for folks here.
Thank you. Yeah, just learning as we did in this study that we did last year, that it was a small group of students, starting with, UC Berkeley, that ignited what would later be this legislation that required medication abortion on campus, and who just refused to take no for an answer, just kept pushing back and pushing back. And as someone who runs our doctoral program and teaches in the master's program, and now with our new SRJ concentration, I truly am hopeful, even though it's not normally my demeanor to be, especially about abortion access. But I really am, because I feel like it's ignited the resistance. And I was at a conference last year where one of the panelists started by reminding the audience that women in particular, not exclusively, but women have always taken care of other women since the beginning, and we will continue to do that. And just remembering that, it just, reignited something. So I'm hoping that everyone who's here is leaving this conversation wanting to take some action. But in case people are feeling unsure of where to begin, if you could encourage attendees and fellow advocates to do one concrete action after this webinar, what would it be? Tamara? Dr.
Okay, in the spirit of keeping it to one, anyone ages 14 to 24, I encourage you to join our Youth Abortion Support Collective, where you can get plugged in for a bunch of other actions and opportunities to learn and support other young people in your communities. So that's the Youth Abortion Support Collective. If we can drop a link, then it's bit.ly/YouthAsk, YouthASC. And so I recommend anyone ages 14 to 24 to join us and get plugged in from there.
I would say, depending on your profession and where your future is heading, find the organization that's associated with it, and then start meeting people and start finding the others that have your passion, right? Within that space, you will then intricately be able to find, what can I do? Because it's usually finding the allies that have already been doing it. You don't need to reinvent the wheel. For example, for me, it's kind of simple for us as OBGYNs. ACOG is the national one. I have a lot of feelings about ACOG, but that being said, you can't make change unless you're inside. So, so I went inside and I'm inside and I'm trying to make change.
I think relatedly, I would encourage everyone to have a conversation, like commit to normalizing abortion in the space where you already have trust and influence, or where you want to have trust and influence. So for example, like if you work in a medical setting, starting an internal conversation about, like, could we provide abortion or miscarriage management here? And I think, like, where are the places where you that have power, that you are technically a member of, like ACOG, like the American Academy of Family Physicians, like nursing associations, the American Public Health Association. Where are you supposed to be a member of, and how can you use your influence and power in those settings to make these bigger systems stand up for what you actually believe in?
Thank you all so much. This has been really wonderful, and we have a ton of questions. I don't think we're going to get to all of them, but I'm just going to pick out a few, and you can jump off mute if it feels like something you'd like to answer. So for the first, what is a good counter argument to those who think that exemptions or compromises to abortion access are, quote, the best we can fight for? Any thoughts?
Um, I always respond with something like that is that we're not free until we're all free. Um, that it is true across all different kind of worlds. Justice is for all, not for one. Um, but we also have to take the wins as we can get them, right? And so being mindful of what we can do, but knowing that the long game is having full freedom when it comes to and full autonomy for our people. Um, and so that's how I usually respond, right? It's that we need to continue fighting, but I also know that working, for example, within the institution at ACOG is that I'm not going to get everywhere with all the things that I care about, right? But if I can even make the needle move little by little, I know over time it's going to work because that's what's been happening for the last 10 to 20 years. What ACOG used to be 20 years is not what it is today. People have completely changed, right? And so while I understand that people can get really frustrated that we're not getting what we wanted or we set out for, right? And it is painful and it's heartbreaking that, like, for example, certain states were only able to like call something a viability limit when viability is a social construct, right? And at the same time, we have to understand that that is in the time we can fight for, and that over time we can fight for more. And so be able to take what we have is still important. So it's a little bit of both.
Mm-hmm.
I'd also add that, like, if abortion is healthcare, we don't have exceptions for other kinds of healthcare, like who can get diabetes treatment when they have diabetes. Like, those are questions we don't ask. And I think, like, in this particular environment, we're also seeing that exceptions don't necessarily work. And maybe this is also where research comes in. Like, we are able to see now through data and evidence that when you have like a life endangerment kind of exception, institutions are still confused about how that applies. And we see the maternal mortality, morbidity consequences because of that. And so now I think if not now, then when are we going to use this data to push for alleviating those exceptions and expanding care broadly?
Mm-hmm. So on that note is another question that I thought about asking also, which is what aspects of abortion care and access do you think are the most under-researched that you'd like to see the field focus on more in the future? It is a hard one when research is not always, when evidence is not necessarily being used to inform policy.
I mean, I'll just say that this is very related to the last question too. We see young people being thrown under the bus, like, and just off to the side a million times when we look at policy advocacy, when we look at research, because there are additional barriers to doing research with folks that are under 18. I understand that for sure. But I think we need more, and we need more to support the culture shift around recognizing that young people deserve autonomy over their bodies as well, and also that young people are having abortions. And so I think that um, there's this kind of additional stigma that a lot of people bring to the table around young people and abortion, where they're like, oh, sure, I'm all for abortion. And then they're like, oh, but not for under this age. So we see that a lot in the policy landscape and policy, where it's like that's a compromise that coalitions across the country are making around like, okay, fine, we'll take out the youth autonomy part. We'll take out the confidential access to healthcare for young people piece. And so we're seeing young people be kind of like the first category to go in broad abortion policy. So I don't know exactly what the research questions are, but I think more research and more research that delineates by age and doesn't group just 18 to 30 in one group. I think that there's a lot of power to separating by age and understanding kind of unique needs of that 18 to 24 or 14 to 18-year-old or even younger than that uh, abortion seekers and abortion havers.
I'm very interested in understanding our like immigrant populations and the lived experiences they have, considering the recent like assaults on their livelihood and their well-being, and how they interact with care. You know, we have like a refugee community, and how we take care of folks who are undergoing that and still have to have abortions and what that is like, I think is something that I would love to see more of, albeit it would be extremely hard to recruit any patients of that and without having that trust. And so, you know, I definitely have patients who do trust me personally, but like, you know, they wouldn't necessarily trust anybody. So.
Mhm. And this next question, Dr. Sun, is for you about procedural abortion training. Do you find you have sufficient training opportunities for your residents as well as outside residents? And this participant works in a New York City family medicine site and are having trouble finding sufficient procedural abortion opportunities for their residents.
Yeah, well, because we are such a large catchment center, we do over 500 abortions a year. Um, and it's probably the most in the state, in the in that half of the state. And in New York City, because there's so many different places, you're probably experiencing a lot of like um, more limited abortion care because there are so many resources in the city. It doesn't mean that people have adequate like needs or like their mean needs are necessarily being met, but they're definitely like it's more limited training. So my residents absolutely get adequate training. Most of them can go off and do 20-week abortions. Um, and so adding a fellowship wasn't a burden. And then in addition to adding fellowships, we have adolescent medicine come rotate with us. We have the pediatric residents sometimes come rotate with us. We do teaching seminars with the emergency department residents as well. So there's a lot of like cross-disciplinary work that we do within our system, because there are so many supportive people, which is really nice. And yeah, and again, it's just about finding the place that could give you that resource, right? We have Planned Parenthood near us that we also train our residents at as well. Yeah. We have it. That doesn't mean that it's the same across all places.
Can you all share thoughts on what New York State should do this year to protect and expand access to abortion care? Are there any priorities that you think should be at the top?
Well, this was raised to me very recently, but it's been on top of my mind for the past few years, and just really the proliferation of crisis pregnancy centers, which I know someone shared in the chat. And New York truly has a lot, which is very disturbing. And they're not regulated. They're often not having like actual trained clinicians or even like real nurses, like to that extent, kind of masquerading as healthcare. And this can be really deceptive. It can be harmful. And we need to find a way to stop them because like uh pretending to be a health center and calling that a First Amendment right is just wrong. And so finding a way to ensure that if people are going to go to a center like that, they know exactly what they're walking into and not thinking that they're getting real health care.
Yeah, so oh, sorry, Dr. Sun, you can go ahead. One of the questions in the chat was about if anyone's conducting research on how unlicensed pregnancy centers affect access to abortion and pregnancy outcomes and complications for people who choose to continue their pregnancy and seek care at those centers. And
There are some research looking at crisis pregnancy centers. And for example, like I think one of our residents did a little research project, and I think over half of our patients interfaced with the crisis pregnancy centers. And they get their phone number, they hound them, they guilt them, they are not real sonographers 50% of the time, they misdate them, they prolong their care. So there's a lot of things. I mean, just talking to the patient today that I interviewed just today, telling me about what happened to her. It's enraging. And the thing is that we have talked about this, like as a community, but they continue to gain traction and gain their First Amendment rights, and then they are funded by the government. So, so what we need to do, I think, is that we need to figure out how to defund their, like these centers. How, and just like what Silpa was saying, is like, how can we make it known that these are fake providers? And they do not give them any, like, they are there with an agenda. Right? How can we make it known that they have an agenda and it's not in the patient's best interest?
So maybe one starter research study could look at patients who are coming to other centers and then investigating from there kind of their experiences that they've had. But yeah, they're well funded, and we were also just told Silpa and I were just on a call with someone who was talking about how a patient went to one of these centers and missed an ectopic pregnancy, and the harms that even people who want to continue their pregnancy for those patients that are happening. So I think I am going to close it out maybe with one more question. This feels like a good one. So how did you all get started in this work, and what advice do you have for current students hoping to get involved in abortion advocacy?
I mean, I will echo some of what Dr. Sun said, but I got started in college peer health education. And so, like many of the students I work with, I supported people my age in getting access to accurate information related to mostly sexual health. And so I would say, especially if you're a student or you're just thinking about how to get involved, get connected to organizations that are doing work that seems interesting to you, or seems in alignment with some of your values. Just like Dr. Sun said, find the people who are doing this work, and then they will become the connectors to different pieces of the work. So I think take the pressure off of yourself to have to know exactly what realm of advocacy you want to get into at this moment. Just start talking to people, ask questions. I think that the idea of networking can be very overwhelming sometimes, but there are many, many people or organizations that need support and need help. And so whether that's, going to a fundraiser for a local abortion fund and meeting like-minded people, or supporting in local practical support efforts around abortion access. I think sometimes one kind of easy entry point can be through some of that volunteering direct service and then meeting people from there.
Yeah, that's exactly what I was thinking, that it's networking can feel intimidating, but we all want to do the same work. Once you go to the place, it feels less weird because you're talking about something you both love, you all love, and you all want to do. And so there's a lot of joy in that, and joy in finding each other. And so I think you'll hear this over and over again, but finding a mentor that you can identify that can help you through advocacy, you can have an advocacy mentor, right? You can have a research mentor. They can be the same, but like mentorship, I did not learn this early in my career, is incredibly important. And I did not understand the weight of that, but it's one of the most important, like, pieces of advice I can have. Find a mentor that you find you have similarities, similar passions, someone who can just guide you, like, and point you to the right direction or can support you when you need to. And how I even got into it, it was very personal, but like, I also have had an abortion. I've had two abortions in my life. And so being an abortion storyteller is kind of how I came to the table as well. And so, sometimes I help We Testify with a couple of things. And so I am part of the group to do abortion storytelling. And it's really helped me bring and normalize it. And then I get to do it in my everyday. Then I get to experience and share lived experiences and hear different experiences. There is so much joy in taking care of people from a clinical standpoint. Yes, there is grief, there is like hardships, and there is setbacks, but there is so much joy in seeing the effectiveness of what we can do, right? Like one small, and then sometimes I think when our amazing researchers don't see it, but that it does happen. You affect amazing change for us all the time. So just putting that out there.
That's right. Even if it's not used right now, it will eventually. So thank you all so much to our panelists for being here, but also for the work that you do. And to our participants, I would like to also shout out Miss Billy Avery, who is here, for whom our professorship is named. Billy, if you want to come join us on camera, please, since you have much to share about abortion advocacy. And in terms of mentors and what students can do if you are looking for a master's degree in public health, please consider this sexual and reproductive justice and health concentration at our school. It is an amazing group of faculty, and we have put our heart and souls into developing the curriculum and are just excited for teaching as advocacy in this next chapter of our school. Billy, welcome. Thank you so much for joining us. I'm
Well,
going to let
thank
you have the last words here.
yeah, well, thank you so much for the invitation. I certainly enjoyed the panel, and I tell you, seeing your faces and hearing your stories and hearing the work you're doing is just so powerful. And we need to, that's one of the ways that we can keep hope alive. We cannot give up hope. And we have to know that, as many of you have said, we are the majority. And you're doing all the good work. You're doing incredible work. The abortion storytelling, the taking care of people. I love the idea. Women have always taken care of other women, and we will continue. But I also want to say there was one point that was made I want all of you to think about. Take time to do self-care, because this work is important. It's hard, it's joyful, it's all of the wonderful things, but it also can wear you down. And we have to be ready to be here for the long haul, because this is not going to be over in a day, a week, a month, or a year. This is a long struggle. And I thank all of you for getting up every day and keeping on.
Thank you so much. On that note, we will leave you all. Thank you for joining us.